Welcome to the Deep Dive. Today, we're jumping straight into the world of pharmacology.
Welcome back. So you've shared quite a bit of material this time, these pharmacology PDFs focusing on congestive cardiac failure, CCF.
Right, CCF. Good stuff in there.
And, boiling it down, CCF is basically when the heart struggles, it doesn't pump blood around as well as it should. Simple as that almost.
Yeah, that's the core of it.
So our mission here really is to pull out the key ideas from these texts about how we actually manage this with medication.
And there are some interesting bits in there, particularly how some drugs seem, counterintuitive at first glance.
Yeah.
It's definitely a multi-pronged approach.
Right. So maybe we should start with what's actually going wrong in CCF. What does the body do when the heart starts to fail? Okay,
yeah. So you get these two main kinds of problems happening. There's what's often called backward failure. Think of it like a traffic jam for blood flow.
Oh.
Pressure builds up, especially back towards the lungs. And that's where you get that shortness of breath, dyspnea, and the trouble breathing when lying down, orthopnea.
Right. I've heard those terms. And the other type?
That's forward failure. Pretty straightforward. The weakened heart just isn't pushing enough oxygen-rich blood out to the rest of the body. So tissues don't get enough oxygen. Tissue hypoxia. Okay,
so the body obviously reacts to this, tries to fix things, right? And I guess those reactions are what the drugs target.
Exactly. The body hits the panic button, essentially. First, the sympathetic nervous system goes into overdrive. Adrenaline-like stuff.
Right, fight or flight.
Yeah, trying to speed up the heart, tighten blood vessels.
Yeah.
It's a quick fix, but long-term, not good for a struggling heart.
Makes sense. What else?
Then there's the RAAS system. Renin-angiotensin-aldosterone system. Bit of a mouthful.
Yeah.
Think of this as the body trying to hold on to salt and water and constrict blood vessels, all to keep blood pressure up. Again, useful maybe in an emergency, but it just adds more strain in chronic heart failure.
Okay, more strain.
And finally, the heart muscle itself tries to compensate by getting bigger. Myocardial hypertrophy.
Bigger muscle sounds good.
Initially, maybe. A stronger pump for a bit. But over time, that thickened muscle gets stiff, less flexible, and actually worse at pumping efficiently.
Wow. So the body's own fixes end up making things worse. It's trying, but...
Yeah, pretty much. These adaptations become part of the problem we need to treat.
Okay, so let's pivot to the treatments then. What are the main types of drugs we see in these sources for managing all this?
Well, we can group them by what they generally do. You've got diuretics. They help get rid of excess fluid.
Okay.
Vasodilators, they relax or widen those tight blood vessels.
Makes sense.
Beta blockers, these are the interesting ones. They actually slow the heart down.
Right, the paradoxical ones.
Then cardiac glycosides, which make the heart contract more forcefully. Sympathomimetics, those give a short-term boost. And then there are some newer approaches, novel therapies targeting different pathways.
All right, quite a toolkit. Let's maybe start with diuretics. Getting rid of fluid seems like a logical first step for that backward failure congestion.
Absolutely. The main goal here is reducing that fluid overload, which directly eases the workload on the heart. It lowers the preload.
Preload. So the amount of blood coming back to the heart.
Exactly. Less volume returning means less for the heart to struggle with. Loop diuretics like furosemide, they're pretty powerful for this, just getting rid of lots of fluid.
Okay.
Then you have others like spironolactone. These are aldosterone antagonists. They work differently, blocking a hormone that tells the body to hang on to salt and water.
A more targeted approach.
Kind of. But with any diuretic, really, you have to watch things closely. Electrolytes, especially potassium and sodium, can get out of whack. And you need to keep an eye on kidney function, too.
Right. It's never just one simple effect, is it? Okay, so next up, vasodilators. Widening pipes, basically.
Yeah, that's a good way to think about it. Yeah. They reduce the resistance the heart pumps against. It's called afterload. Or sometimes they reduce preload, like we just discussed. Or even both.
So less resistance makes it easier to pump.
Precisely. And the big players here, the ones the sources really emphasize, are the ACE inhibitors like enalapril and the ARBs, angiotensin receptor blockers like losartan.
ACE inhibitors and ARBs, heard of those?
Yeah, they're often considered sort of the cornerstone. The key thing is they do two jobs. They make blood flow easier right now, but crucially, they also help slow down the harmful changes in the heart muscle itself over time, that remodeling.
Oh, wow. So they actually protect the heart long-term, too.
That's the idea. Big survival benefit shown in studies. Then you also have things like nitrates, which mostly widen veins, reducing preload. and hydralazine, which tends to focus more on arteries, reducing afterload.
Okay, different tools for slightly different jobs within that vasodilator category.
Exactly.
Now let's tackle the beta blockers. This is the one that feels hard. Why slow down a heart that's already struggling to pump?
Right. It does seem counterintuitive. But the insight here is that the constant stress response, that sympathetic overdrive we mentioned, it's actually damaging to the heart long term.
Ah, okay, so it's like the heart is constantly sprinting when it needs to be pacing itself.
That's a great analogy. Beta blockers like carvedilol, which also has some antioxidant properties, or metoprolol, they block those stress hormone effects.
So they shield the heart.
In a way, yes. By slowing the heart rate down a bit, they allow the heart chambers to fill more completely between beats, and over time, this can actually improve the heart's overall efficiency. But, and this is vital, you have to start them really low dose.
Why low?
Because if you slow the heart too much initially, you can make things worse transiently. So it's always start low, go slow, gradually increasing the dose as the patient tolerates it.
Got it. Patience is key there. Okay, moving on. Cardiac glycosides. Digoxin is the classic example, right?
Yes, digoxin. Its mechanism is quite specific. It works by inhibiting a tiny pump in the heart muscle cells, the sodium-potassium pump.
Okay. How does that help?
Well, messing with that pump leads to a buildup of calcium inside the cells. And more calcium means a stronger muscle contraction.
Ah, so it directly makes the heart squeeze harder.
Exactly. So it can be really helpful for symptoms in people with systolic heart failure, where the squeezing is the main problem. And it's also used if they have atrial fibrillation, that irregular heartbeat, alongside the heart failure.
But I feel like there's a but coming.
There's a big but. Digoxin has what we call a narrow therapeutic index. That means the dose that helps isn't far off from the dose that causes toxicity.
Ooh, tricky. So it's easy to get too much.
Very easy. And toxicity is serious. It can cause dangerous heart rhythm problems, nausea, vomiting, confusion, lots of things.
Yikes. So how do you manage that risk? What if someone does become toxic?
First thing, obviously, is stop the drug. Then you need to check and correct electrolyte levels, especially potassium. Low potassium makes digoxin toxicity much worse.
Okay.
There's actually a specific antidote to digibind, they called it. It's an antibody fragment that binds to the digoxin and inactivates it.
Wow, an antidote. That's handy.
It is, yeah. And then you treat any arrhythmias, specifically maybe lignocaine for certain fast rhythms, or atropine if the heart rate gets dangerously slow. Risk factors for toxicity are things like kidney problems, because that's how it's cleared, low potassium, and just being older.
Definitely one to handle with care. Okay, what about the sympathomimetics? You said short-term boost, like dopamine, dobutamine?
Right. These are generally for emergencies. Like when someone's heart failure suddenly gets much worse, acute decompensation, they're given intravenously, usually in the hospital.
I see. For a crisis.
Exactly. Dopamine is interesting because its effects depend on the dose. Low doses help kidney blood flow. Moderate doses increase the heart's output. Dobutamine is a bit more targeted, mainly stimulating beta-1 receptors in the heart to give that pump function a temporary lift. Short-term support only, really.
Got it. Intensive care stuff, mostly. And finally, these novel therapies. Sacubitril, valsartan, nasiritide. What's new about them?
They represent a shift in thinking, almost. Instead of just blocking the bad pathways, they also try to boost the body's good protective pathways.
How so?
Well, sacubitril valsartan combines an ARB, valsartan, with sacubitril, which is a neprilysin inhibitor. Neprilysin is an enzyme that breaks down helpful molecules called natriuretic peptides.
Okay.
These peptides normally help relax blood vessels and get rid of sodium in water. So by blocking the enzyme that breaks them down, you increase the levels of these beneficial peptides.
Ah, so you're boosting the body's own defense system.
Kind of, yeah. And nasiritide, or BNP, is actually a synthetic version of one of those natriuretic peptides. It's sometimes used intravenously in acute heart failure, again, to help relax blood vessels and ease shortness of breath.
Interesting. So leveraging the body's own mechanisms. Okay, we've covered a lot of different drug types. How does a doctor actually put this all together for a patient? Is there a standard approach?
Well, it's always individualized, but the sources mention a handy mnemonic, the 6 Ds of CCF management. It's a way to remember the key components.
Okay, 6 Ds, what are they?
Diet specifically, low salt to help with fluid, diuretics for that fluid overload, dilators, meaning the vasodilators, especially ACE inhibitors or ARBs, digoxin for symptoms in some specific cases, dopamine dobutamine for those acute emergencies, and finally, disease modifiers that's really highlighting the ACE inhibitors, ARBs, and beta blockers again, the ones that improve long-term outcomes.
diet, diuretics, dilators, digoxin, dopamine, dobutamine, disease modifiers. Okay, that covers a lot.
It does. And the real takeaway is that it's usually about combination therapy. You use diuretics for the congestion symptoms, definitely ACE inhibitors or ARBs, to tackle the underlying disease progression and improve survival. Add beta blockers carefully for their long-term benefits, and maybe use digoxin cautiously for specific symptom control. It all depends on the patient, how severe their CCF is, what type it is.
Right. Tailoring it is key. So thinking about all this, especially the role of those ACE inhibitors and ARBs, let me ask you, based on everything we've discussed, why do you think those ACE inhibitors in particular are often seen as such a fundamental first-line treatment?
That's a really good question. It pulls it together nicely. Well, if you go back to those compensatory mechanisms, that RAS system going into overdrive.
Yeah, the one causing constriction and fluid retention.
Exactly. ACE inhibitors directly block a key step in that pathway, stopping the production of angiotensin II. So they hit two major problems at once. They cause vasodilation, lowering that afterload pressure the heart fights against. And they reduce the hormonal signals telling the body to retain salt and water, lowering preload.
So immediate relief on two fronts.
Yes, but critically, it's also that third D, the disease-modifying part.
Yeah.
They've been shown very consistently to slow down that harmful heart remodeling process we talked about. They actually help preserve heart function long-term and improve survival rates.
Ah, so it's the combination symptom relief plus tackling the underlying progression.
Precisely. They address one of the core maladaptive processes driving the whole condition forward. That's why they're so foundational.
That really makes sense. It shows how it's all connected, the heart, the kidneys, the hormones. These drugs are trying to sort of rebalance that whole system that's gone off kilter.
Exactly right. You can't just treat the heart in isolation. It's about understanding that whole interconnected network and how these drugs nudge it back towards a more stable state.
Okay, so wrapping up this deep dive on CCF pharmacotherapy, it's clear it's not simple. It's a really complex, multi-layered strategy.
Definitely.
You're dealing with the immediate problems like fluid buildup, trying to make the heart's job easier, but also, crucially, playing the long game, trying to slow down the disease itself with those disease-modifying drugs.
It's that balance, isn't it?
Yeah.
Relief now versus better outcomes down the road, and integrating all these different drug actions effectively.
It really highlights how far understanding has come. So here's a final thought to leave you with, thinking about everything we've discussed. Consider those initial ways the body tries to compensate for heart failure activating the sympathetic nervous system, the RAS system. And then think about how so many of these drugs, the beta blockers, the ACE inhibitors, are designed to block those very responses in the long run. What does that tell us about the body's own adaptations? How sometimes the fix becomes the problem? Definitely something interesting to ponder as you maybe look more into heart failure pathophysiology and how treatments have evolved. Thanks for joining us for this deep dive.